Good afternoon, everybody, all the distinguished guests, and my thanks to Government of Uttarakhand, the organizing partner Veloxx, and also the other sponsors for this program. And I'm looking forward for this session. So we have been hearing from the morning, since morning, about the different kind of digital transformation and the need of digital transformation in healthcare. And we also heard such wonderful success stories in Uttarakhand. At EY, we have been in the forefront of being working with the government in close collaboration with the government in the different states, and we are fortunate to be part of this digital transformation both to the center as well as in the states. We have been involved in the Ayushman Bharat digital mission, the country's flagship, the digital initiative, bring its adoption in the different states, to developing the latest technologies in AIML, say OPD assistant, or using blockchain for birth and death registration. So we have been working digital, then again in the insurance sector also, solutions, bringing fraud analytics solution, EMR, EHR solutions for the different states. So I'm fortunate to be part of this digital transformation healthcare journey, which I've been doing for the last 10 years. But I've also encountered a lot of challenges. It's one thing to build the solutions, that software, but the other thing is its implementation and the adoption. I have my panel here. They're all dignitaries out here. They have a lot of experience in the digital transformation. What I would like to have this session is to hear from them the initiatives that they have taken and the kind of challenges that they have faced and how we can overcome them. Okay, so I'll start with first Mr. Narendra. Narendra, you are at the center and leading the government's flagship Ayushman Bharat digital mission, which is what is the way to connect the common citizens with the doctors, hospitals, everybody connected in a digital network. So can you please tell us about this flagship program, the government's ambition, and all the other the programs that are around with this one, and how the government is seeing this digital transformation right sitting at the center?
Thanks, Debopam. So just before I begin, I just like to clarify two things. Like, whenever you think of Ayushman Bharat, most of the people think that there's Ayushman Bharat Jan Arogya Yojana. We have two programs. One is the Jan Arogya Yojana, which is the assurance scheme, which is for, for a set of beneficiaries. And that is also a digital program in the way that it is it is not only the largest assurance scheme in the world, but it's also the scheme which is, delivered only through IT. It is total IT based. So the beneficiaries are identified in the database. You just get an card. They give you a physical card, but the identification in the system and the claims and everything is done through the IT. But what I represent is Ayushman Bharat Digital Mission. So when you say Ayushman Bharat Digital Mission, what is it? It's not a thing that we are not giving a software to anyone. So if I want to explain it, I can explain it in the way that the way NPCI acts for in the financial world. When you go to an ATM, you can withdraw money from any of the banks. You don't need to have an account in that bank whose ATM you are doing. So the money is transferred from one bank to the other, and you get the money. So similarly, when we have all these, some time back we had doctors writing prescriptions on piece of paper. Then certain doctors started writing, using digital system. But still, all these records and everything stayed in the doctor's desktop. He's using a desktop. Or if you go to a diagnostic lab, the records stay in that lab. But suppose someone wants to have a copy of it, it's not available. So what Ayushman Digital Mission is doing, it's connecting all this. So we are acting like a switch to all these systems, and the records can be transferred from one hospital system to the other hospital system, irrespective of which software they are using. So that's what ABDM is doing in a nutshell. Apart from that, what we have also taken on ourselves is two other, riding on this ABDM is, we are creating a UHI. What happens is, we are all used to transferring money using Paytms, and you don't see whether the other person has a Google Pay account or a Beam or any other UPI. So, when you look at services, getting services on using the software. You use Tata 1MG, you can, book your consultations or anything only from Tata MG, the doctors who are on that platform, or any other platform, Practo. Or you want to buy things, you have to go to Amazon, or you have to go to Flipkart. But see, doctors are not this way. It's not like, no, the thing is available. The seller is, contracted to sell through Amazon, but a doctor is delivering certain services. They are curing our illness. So doctors can be available on any of the networks. So through UHI, what happens is if I search for a doctor on any of the networks using the app, I would through Tata 1MG I can search for a doctor on Practo and any other platform where the doctor is registered. So doctors need not register on any platform. So that will happen soon. That all these platforms will come. So it will be platform independent. So I can search for a doctor at any point of time if the doctor is available on a platform. And the other thing which we are doing is National Health Claims Exchange. See, we learned from our experience of processing health claims in the ABPMJY. So it's basically the patient goes to a hospital and the claims are to be processed by NHA. So similar kind of thing in the insurance world happens. But what you have seen, and some of us are doctors, but if you look at from the patient point, uh, if you go to a hospital and the pre-authorization takes place 1 or 2, 3 hours, and the day of the discharge, the doctors come for a round in the morning and they'll tell you at 8 or 9 o'clock that you're ready to go home. But I don't know if any one of you has gone to a hospital and if the doctor has told you to go home at 9 o'clock, and if you have left the hospital before 2 o'clock, it will be a miracle. So that time, because that hospital, the insurance company will say, you have to email this document, you have to send this document, you have to fax this document. Every insurance company gives a different reason, a different model. So what through NH6, what they are trying to do, standardize the information which is required by insurance companies, and also this is it's all standardized, and also it's flowing directly through the system. So what will happen is when the doctor tells you that you can go home, so whoever is the administrator there and the doctor has written their discharge summary, and they click on the button and the claims and everything will go directly to the insurance company in the standardized format. So the company will not say, okay, I wanted this information which is not there, because it's all standardized. So once they have it in a electronic format, even the person who is looking at the who is doing adjudication, they also the task can also be done electronic way most of the times. So that will happen. So hopefully the claim settlement should happen, and we wanted it to be 5 to 10 minutes, but let's say I think if we go before afternoon to start with, that will be a good thing to happen. And uh, one thing which we've talked about ABDM as a transfer of documents, creating digital thing everywhere. So a lot of private sector hospitals and doctors are not coming on board. So we have started a program where it's 100 microsites in 100 cities of this country. We are actually going to private doctors. We're telling them, you can start adopting digital systems. We have made an analysis of the softwares who have become ABDM enabled, and we have talked to those software companies. They are giving it at a reduced rate for some time. So that is happening. So the doctors are adopting these systems. And in the government hospitals, ma'am is here with me. So we have in all the AIIMS in the country, they have adopted digital in a big way. They were actually adopting the digital systems in a big way for a long time, but now more focused effort is there. Like they had gone 50%, now they're trying to go 100%. So I think soon AIIMS will be like, Apollo, when you go there, they don't give you a paper prescription. I think we aim that AIIMS will also happen the same way, that you go to the doctor and the doctor will not give you a paper prescription, but everything will be available to on your mobile. So what we say is, when Reliance launched their phone, they said, "Kar lo duniya mitti mein." So we say, all your records in your digital phone."
Great, great. Narendra, thanks for the wonderful discussion you had. So we kind of heard what the center is trying to do, right? And it is quite successful in its initiative. Now let's hear from Uttarakhand. Okay, we have our esteemed guests out here, Professor Meenu Singh. Okay, if you can tell me a little bit about how you are, and you are in the flagship hospital of AIIMS Rishikesh, I heard that you have been using drones, okay, drone technology to do a lot of transfer of supplies to the rural areas. Can you elaborate on the success of that one, on this the drone technology?
Okay, thank you very much. I thought you were also asking me about the digital, the Ayushman
Sure.
Bharat
Yes.
part also, which is in operation in all AIIMS. And we have been working in the telemedicine space for a very long time. In fact, I had been working in PGI earlier in this space for almost last 20 years. So the problem with telemedicine, of course, can give prescriptions, and we can make remote diagnosis, and we can talk to the patients from a distance and make a diagnosis and give counseling. What always irked us was that when the patient is in need of treatment, when they need medicines, you can't deliver them by telemedicine. You have to have some system by which you can deliver medicines to people at homes. Of course, we had things like NetMeds and all those things where people can deliver for you, like, they do it for food and other things. But in places like Uttarakhand, where we have very difficult terrain, where it is impossible for sometimes for the vehicles to reach, and you cannot have like aerial vehicles also all the time. So we thought of using drones for the same thing. And as you know, drones are of different types. There are some which would be like surveillance drones. There would be some which would be carrying a payload and delivering that payload at a specified site. And as you know, drones use a lot of AI and machine learning, and they are actually programmed in such a way that they go to a given coordinate which is there for that particular geographical area, and it lands there. And there you need to have a person over there who needs to be in touch with you to get whatever has been asked for or what is being delivered, and that is being taken out. And that work is actually right now being done by drone DDs. We call them drone DDs, who are working in the periphery from self-help groups who get some funding, but they are the ones who assist the delivery of these medicines which are sent from AIIMS Rishikesh to various sites in Uttarakhand. And the type of medications which are being sent, initially we had done it with anti-tuberculosis drugs for the patients who are affiliated to AIIMS Rishikesh, because we see a lot of patients of tuberculosis and we prescribe them medicines, and also for drug-resistant tuberculosis. So many times they are short of supplies, and that's the time when we supplement that with drone, and it is given to them to a place which is nearby where the drone can land, and again it is delivered by those people there. And along with that, antihypertensives, anti-diabetic medicine, for because we know we have so much of non-communicable disease also occurring, and for them it has been done. And also vaccines, and along with that, blood products. We also have conducted some experiments with delivery of red blood cells and platelets, because these are the things which are needed at the time of trauma and also at the time of things like dengue fever and all, where in difficult to reach sites, these drones can carry these products. Although people have even been talking about organs, but anyway, that we don't do that much in Uttarakhand. And another application which we have found to be very useful is for these drones, which are agricultural in nature, which are being used for spraying, insecticides onto the fields, which are for agriculture purposes. But these are now being used for spraying on, these insecticides on mosquito-borne areas. All the areas where there is water collection, where dengue and malaria can breed, and that is where before the season, it is. We tried once in Rishikesh, and we are actually tying up with the municipal corporation of Rishikesh, and we've recently had a meeting with them that we, in this particular season, when before the season, we would be doing this spraying, and that would really help.
That's great.
So that is something which we are doing, and we're also doing some cobotics, and that is for collaborating with robots, and in which again the drones can be responsive to the need of the person who's over there. So we are actually working with IIT Delhi and we'll be using this particular technology most likely during the Char Dham Yatra.
Great, great, fantastic, madam. And how long is it operational? This you've been
This
using it?
we started in February 23. We had our first
2 years
experiments, and
This is
it's
a-
going on for last 2 years or so.
So it's a fantastic.
It's become actually, Honorable Prime Minister has launched it all over the country, in all the AIIMS.
All these.
So all the AIIMS, wherever they are, we luckily were in the green zone where we could use drones for all kind of things. There are some AIIMS who can't do it because they are very close to airports and other places. So, but wherever, whatever can be done, people are doing.
This is a fantastic example, which is a combination of physical and digital to reach the last mile connectivity. So really an appreciative effort that we hear from Professor. And I will also ask now Dr. Ajeet. Dr. Ajeet, you have been also, we had a wonderful discussion yesterday. You were also telling me about your experience similarly in the hilly areas and especially on the emergencies, right? There were some kind of a disasters that have happened and how you have used digital technologies for the healthcare digital technologies for the emergencies. So could you please elaborate your experience on that one?
Thank you, Vipul. I've been working in the hills of Uttarakhand for the last 25 years. And 17 years I worked in Uttarakhand district and 3 years in Chamoli. So you asked me the apt question. I've faced two major disasters in Uttarakhand. That was 91 earthquake in Uttarakhand and 2013 flood in Chamoli, Badrinath, and Rudraprayag. So I witnessed everything, and I know that how difficult this is to manage the things in such a tough situation. So I can give you an example. I was not knowing what is happening and what is not happening, but I used a very simple mechanism. 25,000 people were stranded in Badrinath for 1 month. And they had come with the medicine. When you go out, come with the medicine of 1 week or 10 days, not more than this. But they were all diabetics, heart patients, and all people who were taking regular medicines. So how they were, I developed a mechanism for them. And that was a very simple mechanism. I divided Badrinath in 6 sectors and made a nodal officer in the hospital and sector in charge. Sector 1, sector 2, sector 6 sectors. Then I asked the people, I flashed my number there. If you have requirement of any medicine, diabetes medicine, hypertension medicine, anything you require, just let us know. Give a call to DM or to me. And then what we were doing, we were arranging the medicine, sending through helicopter, and telling the sector in charge, this dharamsala, this place, you have to deliver this medicine to this person. So luckily that mechanism worked. And in 25 days or 30 days, people, they survived on those medicines. And I am very happy to tell you this thing, that out of 25,000 people, there was not a single mortality. That was a big miracle. That you are just a cut off from the world, you don't have any hope to the go, just like a digital arrest, what you call. That was a physical arrest by calamity. So that was very difficult. Then one thing I tell you, in Uttarakhand, the most difficult thing is difficult terrains. Uttarakasi, I remember, there are certain places, Liwadi, Fitadi, Sarbagyar, where you have to travel 20 kilometers on foot. How to bring the patient who has got emergency in these cases. Then that time when I was director in HM, we developed this Palki ambulance. The difficulty was that Palki ambulance, we could not get the porters. Professional porters were not there. And village people, they had to be persuaded that they bring their own people, we will pay for it. So they came. But you say, always a challenge to bring a sick person, especially the injured person, fracture with all emergencies, to bring to the nearest facility. And one thing is very, very, very critical here. Every day you read in the newspapers that Garvati Mahila ko sahayata nahi mili. Mahila ko uska sadak pe delivery ho gayi. These things do happen. But why this happened? Because they could not get the transport facility at the proper time. institutional delivery is only 80 to 90% this time. And we want to make it 100%. How could we make it? Only this is possible. This is my suggestion that we should start the sub-center delivery, level 1. Because all normal cases, normal delivery cases coming to Doon Hospital or AIIMS also, is a wastage of time. Is tertiary care centers, only the complicated cases should go. In the secondary, the cesarean and some complications which can be managed at the CSC level or district level, they should be treated. But here what is happening is the hazard of the modern healthcare that people going for headache, they are going to the neurosurgeon. There may be 100 causes of headache. Why not go to a physician first? We have to develop a proper referral mechanism from sub-center, secondary, and then to the tertiary care center. That mechanism. अब जो wellness center आपके हैं, उनमें आपने क्या करना है कि आपने सारे, मैं आई एम टेलिंग द भूटान मॉडल, उसमें क्या करना चाहिए आपको कि आपको केसेस की स्क्रीनिंग करनी है. What happens in the screening? There is a person who has got a gallbladder stone. You tell him, go and to district hospital and get the ultrasound done. When ultrasound is done, then you have to tell him that you have gallbladder stone and this needs to be operated. Now tell me when you want to get operated. And everything is there. You have got Ayushman Mitra. He can work in the wellness center. He will just take the appointment from the district hospital or secondary facility that this person wants a cholecystectomy done. They will say, yes, we can go get it done on from 15 to 20 days. Then in Bhutan, it's a Bhutan model I am telling you. Then the vehicle comes, your home, takes you from your home, takes you to Thimphu, which is a highly specialized unit, gets operated and goes back to Thimphu, to her own place. He does not have to bother. Here, what is happening? Unfortunately, उत्तरकाशी से आदमी आता है, आयुष्मान कार्ड लेके भटक रहा है कि मेरे को कहाँ इलाज मिलेगा.
Dr. Ajeet,
yes,
we have to cover the others
मैं
also.
खत्म करता हूँ इसको. So two things are very important. One thing will be the right referral.
Correct.
Number two, increased transport. And third thing will be delivery of the system. Then one thing very important is we are appointing a specialist in the remote areas, but we have to think that how to retain them. Appointment is very easy, but to retain them for a certain time is very difficult. So thank you very much.
Sure.
These two, three things come, then you have the improvement.
Correct.
Thank you.
So one of the things that we learned from Dr. Ajeet is that having the proper infrastructure and the connectivity, whether it is the transport or the digital internet connectivities, are very critical, such that problems get solved at that level without coming to the cities. Now I will ask Alok ji, as we'll go down to the private players and understand. See, as a system integrator, you have been in the forefront of doing large digital transformations, right? We have done it in other states and everywhere. Where do you see the challenges? Means it is okay to do that, because I have also been in the same area that doing the digital transformation. Where is that the challenges are coming up? How? Okay, if you can throw some light
thank you,
as
Dev.
a private player.
For those who are sitting on the other side, there's a stop clock ticking in front of us, so I'll try to stick to that. I'll answer your query in two parts. One is that when you go for a transformative project like this, you have to have an implementation strategy.
Sure.
Once that is in place, then you look at the challenges. So, I'm now with the private sector, but for the longest years, 35 years, I was with the government. So if we take it into two parts, one is how we go about it. Now, when we talk about transformative digitalization of processes in health, and that too in the government sector, it cannot be a piecemeal effort. It has to be a complete, because then you will not see the results if it is in piecemeal. So, and buying the technology, that's very important. Having at the center an HMI solution will not take you anywhere, because that's like just having a machine. So I'll give you a very brief example. Now, summers are coming. Now, if you buy a mixer grinder, and you say, "Maine milkshake bana liya," so nobody would believe that. So buying an HMI solution is like buying a mixie. But for making a milkshake, you need to have milk, you need to have mangoes, you need to have sugar, you need to have, knives to cut it, and you need somebody to integrate it. So that is what is required when you go for, a transformative project, that an HMIS digital solution is at the center, but then you need connectivity, that is, your internet connectivity. You need devices like, input-output devices. You need a data center or a cloud, and various form factors. It could be a computer, desktop, it could be a laptop, it could be a tab, it could be a mobile. And in the same project, all of them are used. So in a medical college or a district hospital, it'll be a desktop. For the nurses or in the wards, it could be a tablet if you want to do away with the paperwork. Then with the ASHAs, you can have a handheld device or a phone. So you have the form factor, the physical devices, you have the connectivity, you have the cloud, you have the solution, and to top it, you have to have a chef who's integrating it all. So that's the role of it's not a system integrator per se, that's an IT phrase. It's what do we say? A managed service provider, an MSP. So a managed service provider has to be there. Now what they do, they manage change. And what we see, change, that is adoption, is most difficult when we come to the field of health.
Okay.
I'll just take 1 minute. In Bihar, we trained 90,000 Ashas.
Yes.
90,000 Ashas. We started the training in October 24. And today we are on 28th of February. In 4 months, the 90% of 90,000 are almost 81,000 are using every day their mobile devices and everything in Bihar, where the average education of an Asha could be middle or even less. And in local dialect, not even in Khadi Boli Hindi, they're doing it. So that's easy. The difficult part is getting doctors to do it and getting nurses to do it. So that's where you need a change management strategy. You and the technology provider need to walk with them. Because if a doctor say, कि मेरे पास टाइम नहीं है देखने का, मुझे पेशेंट देखना है या आपका कंप्यूटर देखूं, तो you need to give them predictive texting, you need to give them drop down menus. So all that is required, and newer versions of the solutions are required, and constant training is required, and to make sure that things work.
It's a continuous process.
Yeah. So in Bihar, we have each district, we have the troubleshooters, the trainers. They train on a regular basis, and that's how these. There's a solution, but we are human beings, so we have the habit of going back to in our comfort zone. So what is important is that this needs to be done in such a regular basis. Then it becomes a second habit. I'll just end with one thing. I was additional secretary in Ministry of Health, and then I was DG CGHS. When we started HMIS there, my doctor said, हम नहीं करेंगे, आप हमें एक डेटा एंट्री ऑपरेटर दीजिए जो हमारे साथ बैठ के एंट्री करेगा. So I said that will not happen, because and I used to give them the example of SBI tellers in a rural area. तो एक SBI teller पे जो clerk बैठा होता है एक जंगले में in a cage, what he gets 50,000 rupees. He might be just a graduate, and when you go and take your check to that person, he will look at the check, verify your signature, look at the amount, then take the amount from his drawer, count it, give it to you in less than 1 second. तो जब एक बैंक का क्लर्क ये सारा काम ऑनलाइन सिस्टम पे 1 मिनट में कर सकता है, तो मेरे डॉक्टर क्यों नहीं कर सकते? That was my challenge to my doctors, and they were able to do it. So we have to challenge ourselves, we have to walk with them, we have to solve their problems. This will come, but at the center of it has to be the vision of the owner, that is the governments in our case, and the people who are working for them. Thank you.
Thanks. A very good lesson that we learned is that continuous process. It's not a single implementation kind of a thing. It's a continuous process. I will now come to Dr. Sunil. Okay. We heard of the government initiatives, right? How can a public-private collaboration help in the digital transformation, because government alone cannot do it. We understand that one, and you being at AHPI, why don't you
Yeah.
shed some light on this?
Yeah, thank you. I think public-private partnership plays a very crucial role in accelerating the digital health solutions. And as far as the public-private partnership is concerned, we all have very noble examples of these two flagship programs of Government of India, that is ABDM and uh, Ayushman Bharat Prime Minister Jan Arogya Yojana. So I need not elaborate on that. I think we all know that. And ABPMJY, I think 40% of the hospitals empaneled are private hospitals and 60% are the public hospitals. So it is both public and private. And ABTM also, it is a great example. But I will just stress, because time is already up, I'll take 2 minutes, stress on what AHPI is doing. uh, One thing, AHPI has its own digital health committee. It is a multidisciplinary, we have experts from, it's a national committee actually, because we are spread across the country and we have 20,000 members, private hospitals as members. And we have 20 state chapters. In each chapter we have an executive committee who looks after the state health issues, so what we have done is we have this digital health committee. We try to promote digital health among our members. Secondly, we have tied up with the Quaita Foundation. There's one Quaita who is also the chairman of NABH. So we have developed a program called Digital Health Master Class. It's a course for the leadership role in the hospitals, for the CIOs. It's a very basic course module for basically focusing on the EMR and the HMIS. It's a half-day program. So we have conducted in 3 states, for our member states, in Raipur, in Odisha, Bhubaneswar, and in Jaipur. And we have trained about 150 hospitals, the CIOs and the IT people and the leaders, and just to stress the importance of this EMR, and it's a basic course, but it's a very successful program. So this is how we are promoting. Yeah, and another thing, one thing I would like to mention about the public-private partnership, our role, very important role which we are playing as AHPI, is that we work very closely with the Central TB Division for the National TB Elimination Program. We know we are over-ambitious. The world has given set the target to eliminate TB by 2030. But our over-ambitious target says that we should eliminate tuberculosis from India in 2025. And now 100 days intensified campaign is going on. And AHPI has been given the responsibility to engage more and more private hospitals. What we have done, I played a very nodal role in this. I have formed 3 state consortiums in UP, Haryana, and Delhi, consortium of private hospitals to work for this TB elimination program. And totally we have engaged about nearly 170 hospitals which participated. Then we also formed a national consortium. All our state chapters, presidents, secretaries, they came together and taken a pledge that we should eliminate TB, and we'll work towards it, showing their commitment towards TB elimination. So this is how, very strongly we work with the government, because that is our main forte. HPI does a lot of advocacy work with the government, lobbying. So this is what we are doing, so in a nutshell. Thank you.
Thank you. Thank you. I really like the fact that you said about the digital masterclass, because it's the same, I think the same theme is coming up, that continuous training, that adoption thing has to happen so that the success happens at the last mile. I will now come to Dr. Vipul. Okay. Now that we heard about public-private partnership, you are running a successful hospital as a doctor. Okay. How are the private players taking part in the digital ecosystem, and how do you think the government should also be supporting you in this digital transformation?
I tell you, I had not been sleeping well last night when I got a call from the team. I'm a practicing surgeon. And I went to my wife, I said, यार ये 10 बजे मुझे एक टॉपिक मिला है और व्हाट डू आई नीड टू स्पीक अगर मेरे से कहते कि कोई लिवर काटना है, कुछ काटना है. सो थैंक यू एवरीवन. एंड व्हाट आई लर्न फ्रॉम दिस समिट इज practically it is not only doctors who have to play a role. I thank we have Veloxx team sitting here. Thank you. We need a platform like this, many more to come. uh, I had been trained well. And the last time in 2015, when I left Medanta, I had been doing robotics. And from robotics 15, I came back to Dehradun. And, I went back again to those open surgeries. तो मुझे लगता है कि सुबह से हम बात कर रहे थे डॉक्टर्स 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 एंड यू एज यू सेड कि मेरे अपना अस्पताल में आई वाज सिटिंग हियर विद द डिग्निटरीज. मेरा अपने अस्पताल में रोल शायद 2 मिनट सुबह राउंड का है और 1 मिनट शाम के राउंड का है. उसके बाद आई एम रनिंग अ टीम ऑफ 250 पीपल जिसमें शायद 10 या 12 डॉक्टर होंगे. रिमेंबर मी. एंड रेस्ट 200 from my housekeeping to security to front office to my nursing team. So it is not about training doctors. हमारी ट्रेनिंग मुझे लगता है MBBS MS में मास्टर्स में काफ़ी हुई है. अब जब ट्रेनिंग की बात करते हैं जो प्रॉब्लम मुझे उत्तराखंड में लगती है वो हमारी सेकेंडरी ट्रेनिंग है. प्रॉब्लम क्या आती है? विपुल हैज़ बीन वेल ट्रेंड. मैं जब मेदांता में नोट्स डालता था तो मैं कॉन्वेंट पढ़ा हूँ, मेरे नोट्स अच्छे होते थे, लेकिन मेदांता मुझ जैसे के पे करने के लिए 2-2 लाख रुपए तनख्वाह देता था. विपुल केम बैक टू देहरादून. विपुल कैन नॉट पे 2 lakhs हैंडसम सैलरी. तो मुझे छोटे रिक्रूटर्स रखने होते हैं. जो डिजिटलाइजेशन की प्रॉब्लम है जो सर कह रहे हैं, तो व्हाट आई डिड वाज मैं अपनी टीम के साथ बैठा और मैंने अपने TPA डेस्क से कहा, जो उन्होंने कहा कि 3 घंटे वेटिंग प्रॉब्लम वेटिंग. मैंने कहा तुम रात को ना डिस्चार्ज रात को बनाया करो. सो एज आई सेड कि ये प्लेटफॉर्म और वी ऑल एज अ इंडियन शुड टैप आवरसेल्फ कि हम लोगों ने ये जनरेशन बैठी है, हमने ब्लैक एंड वाइट से LED होते हुए देखा है. हमने आई रिमेंबर माय दादा टेलिंग मी कि ही हैड टू गो टू वेलिंगटन RML फॉर माय ग्रैंडमदर सर्जरी और उसकी 3 महीने वेटिंग है. आज वो सर्जरी उनका ग्रैंडसन देहरादून में है. आप आज बोलो मैं कल कर सकता हूँ. So yes, we as Indians have done very well for ourselves talking about healthcare. Now we have friends in whether it is Europe, America, everywhere. And as an Indian, I should say, even in America, we are proud to say the best doctors are Indian. So आज का healthcare innovation का मकसद ये है, we need people like Mohit on the stage who could share this, luckily, the reason Vipul was here, the main reason, I tell you frankly, was to meet my minister, my secretary. My reason was to meet them, to say hi to my bosses. So, ये एक platform मिला where I was easily accessible to them. I could tell them my problem. But the main initiate is to train our population. And if our population gets trained, which I am seeing it, see, Rome was not built in a day. So nothing can be built in a day. तो लेकिन हाँ, हमारी पॉपुलेशन को हमें नीचे वाले को सिखाना पड़ेगा, भाई तुझे TPA का काम करना. आई टेल यू कि मेरे ICU में आई इनवाइट एवरीवन ऑफ यू टू कम टू माय ICU. सी माय नर्सेज, यार मेरे से अच्छा वेंटिलेटर वो मैनेज करती हैं. सेंट्रल लाइन अगर कोई डॉक्टर सेंट्रल लाइन मेरे से अच्छी वो डालती हैं. स्टिचेस मेरे से अच्छे वो लगा सकते हैं. सो द कंक्लूजन ऑफ दिस इज दैट वी नीड टू ट्रेन. इट इज नॉट द डॉक्टर्स, इट इज the associated paramedical and everyone who's associated with healthcare. Whether it is my minister, it is my secretary, we need to be in a same boat and help each other, hold each other's hand and grow this India up. So with this, I would end my words. Thank you. Thank you so much.
Thank you, everybody. I think we have heard the success stories from everywhere. We are also hearing from them, they're all experienced people, that the digital transformation, the success will only come if we do it on a continuous basis, if we bring the last mile to us, which is the digital literacy, able to overcome the kind of hesitation people have in adopting the tools, and that can come through continuous, change management, spreading the information, having these kind of conferences. So thank you everybody once again for sharing your experiences. Thank you.